Hello and welcome. I'm Professor Khalid Khan from University of Granada. Today we will talk about discrimination in provision of healthcare. To discuss the topic, I have with me Dr. Marta Maes. Marta, can you please introduce yourself?
Yes, of course. I am Marta Maes, a general surgeon at Public Hospital in Verín, specializing in breast cancer and aesthetic and reconstructive breast surgery. And today we are going to talk about gender bias in clinical practice cancer guidelines.
Okay, so we will cover this paper that I have the privilege of having co-authored it with Marta and other colleagues. Uh, Marta, can you just explain what is shared decision making?
Yes, of course. Shared decision making is a process that integrates the physician's knowledge with the patient's desires and needs, with the goal of making the best decision regarding their illness. It is based in three fundamental pillars, which are the scientific evidence, the clinical expertise of the professionals providing the information, and an innovative element, which is the patient's preferences. So in the integration of these three pillars is where the decision should be individualized for each patient. The first premise is that there are no right or wrong decisions. They are tailored to each patient. And the main objective of our study was to evaluate gender bias in the recommendations of shared decision making in clinical practice guidelines for these two common gender specific cancers: prostate cancer for men and endometrial cancer for women.
So the key issue here is that women and men
Yeah.
should be treated equally by the healthcare system. And we are able to test this through the study that we've carried out. So, can you tell us a bit more about this study, Martha?
Of course, yeah. We did a systematic review of clinical practice guidelines from 2015 and to 2021, registered it previously in Prospero, and we searched it in several databases such as Medline, Embase, and professional society websites. And the inclusion criteria was clinical practice guidelines focused on the diagnosis or treatment of prostate and endometrial cancer. We also evaluate quality of these guidelines with a 31 item tool
Sure.
already validated. And the conclusions were that we found 84 clinical practice guidelines and 13 consensus for prostate cancer, and 67 clinical practice guidelines and 12 consensus for endometrial cancer.
Martha, why are guidelines so important in clinical practice?
Well, they are very important because they support evidence-based medicines, and the consensus also ensures that recommendations will be widely accepted within the profession.
Okay, so the guideline ideally should make a recommendation in respect of shared decision making. The expectation should be that the guidelines for women's cancer recommend shared decision making equally compared to guidelines for a cancer affecting men. And what did we find?
Well, the main results were that there were differences in shared decision-making recommendations. Regarding prostate cancer, 47% of the guidelines included recommendations for shared decision-making, while only 17, no, 16, sorry, so only 16 of the endometrial cancer incorporated shared decision-making in recommendations. Um, Regarding specific areas such as practical implementation of shared decision making, we have also different results. And actually, prostate cancer recommended shared decision making in 16% of the guidelines, while only 3% of the guidelines in endometrial cancer recommended shared decision making. And regarding declaration of shared decision making value, the differences were also important. 25% of the prostate cancer guidelines recommended shared decision making, while only 10% of the endometrial cancer recommended shared decision making. So, in conclusion, we confirmed gender bias. Guidelines for female exclusive cancer address shared decision making less frequently, despite critical decisions such as fertility preservation or induced menopause. So we also acknowledge that lower priority was given to women health policies. There were a lack of visibility of shared decision-making benefits in gynecologies, and the risk of less informed decision for women was addressed, and missed opportunities to improve cancer care quality and equity.
Martha, this is very concerning. I mean, the guidelines are made by healthcare professionals. So we're discovering here that healthcare professionals themselves are treating women differently when they are constructing the recommendations for the guidelines. What can we do about this in the future?
Well, of course, we need to walk from a paternalistic model where the doctor acts like a guardian, deciding what is better for the patient, to a deliberative model or the shared decision-making model where both doctor and patient decide together what is the better treatment for the patient, taking into consideration the personal situation of the patient, the preferences and the values of this patient. And finally, we can resume these recommendations in, for example, incorporation decision making into future guidelines, as they are a fundamental pillar for clinical practice. So we have to ensure specific tools and resources for implementation of shared decision making. We need to raise awareness, so we have to spread knowledge of shared decision-making benefits in academic and clinical forums. We need to monitor progress, creating, for example, indicators to evaluate shared decision-making inclusion in new guidelines. And we need to promote equity, including gender analysis as a standard criterion in clinical guidelines reviews.
Okay, Martha, thank you very much for joining me in this video.
It is a pleasure, as always. Thank you so much for having me.